Good afternoon, everybody, and welcome to UCSF Family and Community Medicine Ground Rounds. I'm incredibly excited about today's Ground Rounds. We have a wonderful speaker, but just before we start, a few quick announcements. As a reminder, this session is recorded, which means it's recorded. It also means that if you want to review parts of today's session, or if you've missed previous Ground Rounds and you want to see them, they will be posted on the UCSF FCM website. You can go check them out at any time. Also, as a reminder, today's session will be in webinar format. We have a phenomenal speaker who is really interested in hearing questions or seeing questions. So if you can type your questions into the Q&A, I will keep track of them, and then she'll be able to answer them for us at the end, which is exciting. Or if you just have comments that you want to make, please enter them into the Q&A. As always, will be an evaluation for the session, just to give feedback to us and to our speakers. If you want to click the link, we'll send it out in the middle of the session. Before we get started, I also want to give a really special thanks to Ben Wallen, Erigo Mitchell, and Roy Johnston for being our tech support for this session. And now, with no further ado, I want to welcome Dr. Ayanna Bennett. Dr. Bennett will be talking today about moving from intention into action on health equity. In our post-George Floyd world, many organizations and individuals have committed to eliminate health inequity. However, many seem to focus on generating and understanding goodwill rather than concrete change. Dr. Bennett will discuss today a framework for health equity implementation that the Office of Health Equity is developing at San Francisco Department of Public Health, DPH. This is an evolving framework, but the best practices around health equity are all evolving, and this framework is offered as one potential approach. Our speaker today, Dr. Ayanna Bennett, is the Chief Health Equity Officer and the Director of the Office of Health Equity at the San Francisco Department of Public Health. Dr. Bennett is a pediatrician. She trained for her MD at UCSF and at the UCB-UCSF Joint Medical Program for a master's degree. Shout out to the JMP. In 2004, Dr. Bennett co-founded a nonprofit in the San Francisco Bayview Hunters Point neighborhood called the Third Street Youth Center and Clinic, which today is thriving. Dr. Bennett led Third Street as its medical director and then executive director for 12 years, while also working as a practicing pediatrician in the East Bay. Dr. Bennett transitioned fully to the health department in 2015, taking several leadership positions before establishing the Office of Health Equity in 2019. The Office of Health Equity focuses on four main areas: creating a diverse staff with health equity competency, reducing health disparities, supporting a culture of accountability, and authentic community engagement. And I am incredibly excited to welcome Dr. Bennett today. Thank you for joining us.
Thank you. I am happy to be here. I'm a bit of an evangelist, and strangely, racism is my favorite topic. So I will enjoy this, and hopefully you'll have something to say, and we'll have a little bit of a dialogue, and we can both enjoy it. So I'm going to share my screen. Give me just a moment. Oops, I did the wrong one. No, do you have the right screen? Okay. I really can't tell. Do you have the right screen?
We can see your Windows bar at the bottom there.
That's the wrong screen. Okay, thanks a lot.
Sure.
Not sure why I did that. Did that do it?
It's about the same, but I think it's okay if you can advance your slides.
Okay.
Oh, there it goes. Perfect. That's
okay,
good.
Perfect. Okay. So you are, I'm sorry, folks, the way that worked didn't work for me. Okay, there we go. So I come to this work as a practitioner first. Most of the health equity work I've done has been trying desperately to create health equity out of nothing in the Bayview. And I really, really would like to bring that outcomes focus to the work that I've seen institutions do. It is not there a lot of the time, and I really want to focus this talk on how do we make that transition. It's a difficult one to go from doing a difficult conversation to actually taking difficult action. It is not a small step, but we need to take it. And this tree, this apple tree, is my metaphor for that. I really like this metaphor, so I'm hoping that it's one that you understand. We have all been really trying to grow in this area with beautiful trees of understanding and goodwill, and this is our anti-racism tree. It does not matter unless we get fruit. Still not seeing anything. What are you seeing then? Someone's texting me they don't see anything.
Yeah, I'm seeing, Ayana, I'm seeing just the video, the UCSF Zoom connecting to our community.
That is so odd. Why does it keep doing that? It keeps giving me a different screen than the one I choose.
Would it be okay if we just ask Roy to start running this?
Last chance.
That's working.
There you go. Now we're seeing it. Thanks.
All right, whatever.
Perfect. You got
so it's a tree. It was a tree, just me describing it. But so it doesn't matter unless it bears fruit. So these things have to be something that people can actually feel. And the reason for that is that folks are starving. So nobody cares about your apple tree if they can't eat the apples. Some of it's low-hanging fruit, some you have to climb for. I don't care. The only point is that if nobody's eating it, you have then grown a useless tree. So it's not about beauty or things that look good. It is about whether or not anybody's less hungry. And this is the same thing. Did people not die now because you did whatever you did? Do people work here who didn't work here? Do people not quit who otherwise felt harassed into quitting? So whatever your outcome is, you need to set an intention that is an outcome, not a feeling, not a state of being, not an awareness. And that intention needs to be something that can only be reached with action. So that is where I'm trying to get us. So we move forward. So I'm going to give you a little background about the Office of Health Equity, just so you know where all this work sits. So we, as I said in the intro, work in 4 areas: workforce and capacity building. It doesn't really matter entirely what the diversity of your workforce is if those people don't have a skill set. Most workforce issues aren't going to be hired away from. Like, we don't have that many open positions. We can't just magically change the diversity. So we're actually going to have to change the behavior of the people who are already there. And that's infrastructure training, things like that. Health disparities. We actually have to use quality improvement programs, metrics, the things we know how to do to not just improve quality on average, but improve quality across the board. Community engagement means more than just flyers and outreach, but partnerships. Who gets to set priority? How much do people know about what you're doing, and how transparent is it? And then accountability. We very rarely get change without some structure in which people are watching to see whether you did it or not, and some consequence for failure. So that has to be there, and that's planning, reporting. It might even just be public embarrassment that we didn't do our job, but there has to be some format. And so the Office of Health Equity is a central core of people. It'll be about 14 in the next year. Strategic planning, alignment, oversight, those are the things that we offer in these 4 areas. And we basically are facilitating everybody else's work. There's the first thing we did was build infrastructure, and that was before even establishing the office. So there are equity leads, mostly manager level positions in every part of the department. The one for ZSFG, where many of you work, is Sophia Lai. She is out on leave right now, but she is your lead and has been facilitating folks starting work in their particular areas. The other thing I do a lot of is leadership coaching, and I'll talk a little bit about that at the end. And then, of course, training, which this is one. So I'm going to give you an example of a little clearer than maybe my tree about what we mean by intention and action. And I don't just mean doing anything. So I'm going to point that out to you. So I'm going to use a COVID model. I did a lot of COVID work. And so this graph, which is vaccine rates for kids 5 to 11, is pretty much what we saw about a lot of things. If you look, the Latino and Black kids in that age group are getting vaccinated less, at least at this time point, where our vaccine numbers look better than that now, but at one point. And so we did things. We had trusted messengers. I got to do a lot of those Black doctor consortiums. We did education, Spanish, we did every language. We have lots of posters, and we did access. So we went to people's churches, we had tents, we went where the people were. Those are all really worthwhile actions. They're all the first things everybody thought of, and we absolutely need to do them. But the action I'm really talking about is that long-term sustained action that is really about the way the system functions. It's institutional and systemic racism, not situational and momentary racism. So this is situational. It is not momentary, but it's hopefully not the rest of our lives that we're in this emergency. And so those are not the kind of changes that I'm talking about. So what I'm talking about is underlying any problem, including this one, is that there are policies, people, and programs that either are present but not operating correctly, absent, that are causing that system to operate in that way. So if people aren't coming in for vaccines, maybe it's because they didn't see a poster in their appropriate language. Maybe it's because they were suspicious of whoever you had send the news. And maybe it's because they can only get to their church and not your clinic. Maybe. But maybe it's about the way you operate your system that makes them unable to use it. And that's why you saw those differences. So it's at least worth asking the question. Those three pictures, if you are in the DPH system, you probably saw them from the sort of intro to health equity training we made everybody take that we started at DPH, but I'm going to tell that story again. So these are the kind of actions that I'm really talking about when I say moving to action. So this is how I explain the model. And I've been working this out really with managers and other folks who've been trying to make changes in their area. And some of this is based on examples of excellent work in primary care, of excellent work in behavioral health. So I will unfortunately not credit all of them because this is a time-limited event, but this is the work of really dedicated people. So the framework that I'd like you to at least think about using is to do these 4 steps. And the first is assess, determine your readiness. Is your team, your organization actually ready to do this? Implementing in a group that is not really admitting that the problem exists or feeling uncomfortable with the discussions, you cannot really do something that you also don't want to talk about or look at. So are you actually ready to do this? And then determine your capacity. Do you have the data, the authority, and the funding? So that authority one is one people often miss. The revolution is not going to happen because someone in the management structure wanted it to. It is going to happen within your scope. So you have things you control. What are those things? And some of those are generating racism because almost everything is on some level. So what is the data and the funding that you can put to the things under your authority that will make change? And then specify, so know your population. So what are the problems that that population has? Those things go together and be specific, and then address it. So address enabling policies. So when we distribute risks and rules and benefits, we do not do that evenly. We do it based on race and lots of other social factors. And so what are the policies that are allowing that misdistribution? And then address the risk of bias exposure. So these are personal interactions with people who are expressing racial animus or just bias, just carelessness. It can be a lot of things. And then the last, if you need to do it, is design new interventions. You don't always need to do that, and it tends to be where we go first. And so resist that one till the end, because the others are the ones you're more likely to miss. So what do I mean by assess? So we have been using the GARE framework, which is the government accountability on race and equity. So that's a national group. It's part of Race Forward, which is also a national group that does policy and practice change around racism. So this framework is being used by about 200 or so municipal groups, and those are states or counties or individual departments. I think they might be as high as 300 by now. And they recommend these 3 stages, which I found to be very true and very useful. The first is to normalize. So you need to have a priority and a shared intention. And the reason you need those things is because you need cooperation of staff and you need the authority. So you need people above you and your peers and people on the front line to actually want to do this thing. It is actually not possible to force people to do things that they constitutionally object to. And racism is a topic many people have feelings, but not necessarily a lot of worked out thoughts about. So it can be hard. Organize, you have to have funding and staff. If it turns into a voluntary mission, it is likely to get subsumed by some other priority at some point. So it has to be an organized effort, not just a voluntary crusade. And then operationalize, which is the stage I'm talking about. You have to actually have changed something. Your policy, your practices, your processes, something actually has to change in the end. And why does assess go first? That is a swing and a miss right there. And my statement to you is you only get so many swings before your turn is over. So people will give you a certain number of chances to look at their very personal and important problem that is hurting them or causing them distress. And you say you're going to fix, and you can fail to fix it a few times, but then you've lost them. And by losing them, it means that cooperation authority that you need is gone. So people won't prioritize it again. You don't have allies anymore. You've lost the trust of the people you're trying to help, and therefore they don't actually use your program or care about your intervention. You lose your investment because we like things to give us a return on our investment, and you've lost focus. So something else will take over. So don't start something that you don't have very good reason to think will actually be implemented or even succeed. So next is specify your population, and there are lots of ways to specify. The first is specify your problem. There are lots of disparities. If you go looking for one, you will find it. Every once in a while, the group that's the most affected will change, but not by a lot. It is in our area, Black, Pacific Islander, Native American groups, all in this town, small populations, all have worse health on most indicators. And then look at that group compared to everybody else. This is a great example from primary care, in which they looked at their vaccination rate for COVID vaccine. And that comes from first seeing the data on the rate of infection with COVID-19, which was in itself disparate. The vaccine rate is disparate. And then they went the step further, which is to look at what your point of leverage is. So what are you doing? Where do you occur? Sometimes we stop at the population isn't, that it's happening differently for different populations and think, is it grocery stores? Is it something external? It probably is. It is grocery stores. It is something external. And then we look at what is it that the population is doing? The problem is in the people. They don't understand. They can't get there. All kinds of things that exist in the person. It is a habit of racism that we look for the problems inside the bodies of Black and brown people. Why do I have a problem? If there's a Black or brown person in the vicinity, there's a reasonable chance you can come up with an easy answer that places the problem inside that person. Do that and then try to get past that lazy way of doing things and go look at what you're doing. So this is, I think, a really brilliant example of doing that. This is them looking at the vaccine offer rate. What are their actual staff doing as they're part of making the vaccination rate more equal? And initially they started with a low rate from what their goal was, where only 74% of Black African Americans, that's the orange, were getting their vaccine offered when they were in contact with the system, 81% of everyone else. And if you look, that rate goes up. And for a lot of that period, the gap doesn't. So that's what often happens when you improve something. You tell everybody, do it better, and they do it better some of the time. And that difference that they had in the beginning persists. It did get better by the end. So you've got 7 points goes down to 4 points, which is a great improvement. Everybody was getting vaccinated much more. And then you get even your lowest group, which is not even, but you get them over your threshold, which is your goal. If you had looked at whether the average got over the threshold, you would be celebrating in May of 2021. When in fact, it took till December to really get everybody over the goal. So that is the way in which we need to be more specific. And then eat up. So just we're moving into address. And here's some ways to address, and I'm going to go over different types of addressing the problem. In this one, I'm going to talk about institutional racism, just like that offer rate or various things that you are doing. These are problems that you actually have control over. So in this slide, you are 15 minutes late, mom and child, you need to go away. So that is a policy we decided. There's no magic about 15 minutes. Somebody just decided that that was the line at which we would draw the line, and that it should apply to everybody equally all the time, to the point where we can just put up a sign or tell the front desk to tell everybody that. So my metaphor, and I'm a poet by nature, so I have a metaphor for everything. It's not just the tree, sorry about that. In this case, it's pandemic. So a threat that enters through points of vulnerability. The Laguna Honda response to COVID was a great example of this. And I think that we've had some responses to racism that follow that example. So you have a point of vulnerability. How is the problem getting from one person to the next? In terms of COVID, it's by one person and it's physical proximity, and they have to come in, and it has to be a staff person because the patients don't leave. You can think through a lot of the logic of how does it get here. The same is true for racism. It's mediated through things. It doesn't hurt people from just being in the miasm of the air. Somebody has to deliver it. So you have rules and restrictions that are unevenly applied. You have enforcement mechanisms that might be giving it to people. You have resource restrictions that keep whatever you've got from getting to some people rather than others. And the risk is highest for those with a pre-existing injury or less reserve. So the people who are more likely to encounter the biases in your system are those who get it from everybody else too, and don't have as much resources to make up for whatever you're causing. So they don't have help to get out of your enforcement. They don't have resources to overcome your resource restrictions. So you're likely to get the same people that are already being harmed, and you're likely to harm them in ways they can't fix. So what is your response? It is to interrogate your current policy. So you can't do all of it at once, but only some of it is in your purview to enforce anyway. So look at that first. Decrease power imbalances. So giving yourself the power to enforce things creates an opportunity for you to do that in a biased way, giving yourself the power to distribute a resource rather than have it be distributed on some system or distributed by people's voluntary taking of it. Anytime you're giving yourself power, you're creating a power imbalance, and those can be dangerous in this case. And then update outmoded methods. Lots of the rules and policies we put in place were put in place by people who, learning that it had a racist outcome, would be unbothered by that. In fact, may even have intended that. So if that rule has been there since 1935, there's a decent chance that an entirely racist outcome would have been expected and or accepted, and therefore probably should be looked at a little bit. And the last is surveillance. So we need quality improvement mechanisms and metrics on these things. You should be disaggregating everything. And then evaluation of the policy application. So yes, we have a policy, but it results in something. And so you should be able to say, I'm interrogating whether this policy should stay. This is what it results in. You should know what that is. So if it's enforcement, it results in people having contact with a sheriff. If, whatever it is, there is some metric you could be looking at. So addressing enabling policies, and the formula I like to say is bias plus power equals impact. Your personal biases without the power to inflict them on anybody else are irrelevant, at least to your workplace. And we are not, I hope, in the business of changing hearts and minds. That is a strategy. It is important to be in there, but that is not the thing that is probably going to be the easiest to change. The easiest to change is the power, because that is delivered by you. So people don't inherently go to an institution and have power. The institutions decide who has it. So in that case, I like to think of racism as a choice. It is mediated through choices. So either the system has made choices that allocate resources and burdens, or it's a person who has a worldview or belief that there's a hierarchy of human value based on skin color, and they mediate their choices through that belief. And so system choices, people choices, we're talking about system choices when we're talking about policy. So looking at different kinds of policy, medical policy ratifies racism. So when there is a medical policy, particularly when it's around healthcare, it creates a veneer, just the way science has done for many years, a veneer of respectability around racism that is sometimes hard for the people who are doing the enforcement to actually understand. So these are some examples of places where people are actually trying to notice that. Race corrections and clinical algorithms, GFR, And then one I want to talk a second about is the Black NFL players who were impacted by a pseudo-medical practice of race norming cognitive tests. So in the racist view of the person who originated the test, when in their heavily racist time period, you wouldn't want to judge a Black person as deficient when their cognition is lower, because it's always lower, or it should be, right? That's their worldview. So if I have lower cognition after being hit in the head 50,000 times in the NFL, that's not our fault. You already had cognitive problems because you're Black. Therefore, I don't have to pay you. They saved themselves millions of dollars. They had to correct it eventually, but that would not have been possible without the endorsement, sometimes unwilling endorsement, of people in medicine. And we are doing that same thing to ourselves. People don't get their kidneys because we say their GFR is different than it should be. So there are lots of different ways. Muscle mass, cognition, lung volume, there are lots of different ways, and some of them may in fact be useful or show us something real, but probably not. So we should probably look. Policies add power to bias. So that is our friend in the park, who there is a policy, but it doesn't, if you don't have that policy, then it does not matter that she would prefer some people not be in the park doing things. That's true for everything. So we have a policy about screening infants for drug abuse in newborns. I can guarantee you, CSFG included, that is not a policy that is equally applied to people. Even if you look at the characteristics of the people other than race, race is a powerful dynamic in determining who gets screened for drugs. Public health nurses in the DPH system did a great piece of work on this, in that looking at their own policy of closing cases after multiple attempts to reach a person. So I'm trying to reach a mom so I can help with her baby. I give it a couple tries and then I stop, and I'm allowed to close that case. Cases were getting closed under that policy, properly under that policy, many more times for Black women than they were for Latino or white women. So it's not that the policy wasn't being enforced, it was that it was being differentially enforced. And so just because the policy is in place doesn't mean that we're using it in the same way. The policy itself may be fairly even-handed, but the people who are choosing whether to do it or not are not necessarily. And then this is the two things you're seeing here are the park a few blocks from my house. They are calling that a park. And this is the park a few blocks from my child's school. So these are the same park department in Alameda County, Oakland. And they, this one, trust me, within 500 feet of this park are about 50% Black people. And this one is, I've been in that neighborhood, about 1% Black people. And they are the same department. So there's a policy about how much we spend on parks, but unless somebody is looking about where you spend it or some oversight, it is likely not the same. So identifying targets for standardization. So clinics set vaccine target, the patient's called with a vaccine offer, you do a workflow all around. So there are points in there that are choices. Do we disaggregate that data or not? Do staff have the cultural competency when they're calling people to not offend them or make them not want to come? Do patients have input on the messages when they're when you're trying to convince them after they refuse? So there are points at which you can find to do your work, do look at them. And then the active policy analysis, I just want to highlight one thing, that it really is the search for hidden impact. So things like no marijuana, I'm only going to talk about one of these, no marijuana sales near parks is one that happened in the Department of Public Health. That was the rule that was put in place in the legislation. But if you look at the segregated history of the city, you realize that there are far more parks in whiter, richer neighborhoods than there are in Black or poorer neighborhoods. And so where can I put my marijuana dispensary then? Where can I manufacture my edibles? You can manufacture them in Bayview and you cannot manufacture them in Presidio. So there is no racial underpinning to that policy, but it doesn't matter. It is being spread across a racial geography. It is being spread across a racialized set of workforce issues. whatever you're doing, there is likely some impact underlying it that you did not create that you have to take into account. And now we're on to program. Okay. Interpersonal racism, people looking at bias exposure is what I'm talking about here. So in this case, that nurse is really unsympathetic about going against the rule about whether or not these people are late. So she has the power to overrule that. We don't exactly interrogate whether or not the nurse should have that power, but they do. They let people through all the time. And in this case, she's not going to. And trust me, we do sometimes do that. My metaphor for that is asthma. It's constantly there, that bias, but it's only a problem when it's triggered. There's lots of good research that bias is not operable all the time for most people, and that anxiety, rushing, being isolated from the group most of the time, depersonalization, like you're looking at people as numbers, policing power, giving somebody the policing power, all of those things trigger them to behave in a biased manner. So that is a thing that is going to trigger them to have their bias response that everyone else will then be exposed to. So training people to have some awareness, doing calming things, doing testing of whether or not people are in that state by asking for patient and staff feedback from the people who are the likely targets, doing bystander interventions. You see somebody who's over there wheezing their bias all over the place, maybe you step into it. And then prevention, minimizing choice points so that you don't have to have things be a point of choice. There is an art to medicine. We don't want to be inflexible. There are all those things, but also you don't want to put power in places where it doesn't need to be. And then you have a control plan for exacerbations. So if this person or that person or someone is going to have this happen to them, you need to have metrics for when you're doing inequitable care, for when you're doing poor quality customer service, so that you can actually tell when it's happened. And then that is the people choices. Talk about that for a minute. So racism in medicine can look like just a personal choice to do less, whether there was any policy around it or not. So non-Black, Hispanic, non-Hispanic, Black, and Hispanic children were less likely to receive diagnostic imaging during ED visits compared to non-Hispanic white children. That is just somebody decided you need a X-ray or not. And these were normed for the type of injury the kids had. It didn't matter. So I'm gonna give you one more. Minority, and this is to do too much, minority children and children without private insurance were evaluated with skeletal survey, which means I'm looking for evidence of long-term abuse more often than white children with private insurance, despite lack of evidence to support this practice. So there's nothing different about their presentation or what they said, but it just happened more often. So we have personal choices, and it's not just nurses, it's doctors too. Interpersonal racism is commonplace. So that is one thing I think we forget. There are not special costumes for you to be racist in. It's just kind of being an everyday person. So we guess, which is the way what bias is. It's a guess when we don't know, can't think, or feel expert already. So we're not being our Sherlock Holmes self. We're not calm, methodical, integrating information, open to complexity. When you're in that state, you're much less likely to be using your biases. You don't need to, but we're not always that way. Sometimes we're emotional and tired and rushed and reactive and assuming simplicity because God, you wish it was simple. So that describes many of us during our workday. And so the work is a place where you would expect you're going to see more bias. Just some hints on managing bias. There's pretty good research that it's not easily managed. So it is really hard to get long-term impacts no matter what we do, but you don't necessarily need a long-term impact. You need to be able to decrease triggers to decrease the likelihood. So you can decrease triggers by alerting others to choice points as an entry point to bias. So tell them when they have to be worried about it. Note where your risk areas are. Design environments and workflows to avoid those triggers. So do people have to be rushed? Do they have to look impersonal? I mean, can I personalize it by having you not have 27 charts in front of you? Can you communicate about people as individuals? So comment on things that are specific. They are a woman, a child, they have a birthday, they have family members, they came as a group, whatever. The more specific they are, the less triggering it is for people's biases. and then decrease the impact of it. So design your process to mitigate inconsistency. So you have some quality improvement standards. And then if everybody gets at least that standard, you can at least have some sense of equal quality. And then tracking individual performance, which is the harder thing to do, but we have done in some cases. So if you're looking for an action to happen and it is not happening equally, who is doing that? It is likely not every staff member. It's some few people. And so being able to concentrate your training and your tracking on those people, I don't mean surveil them, I don't mean follow them or blame them, but if it is a thing that's happening across 20 staff and it's actually only 3 people who are causing that change in your data, it is inefficient to try to do something to 20 people so as not to target 3 people. We need to get the idea that it's targeting out of our culture in a professional way so that people can realize this is a thing they need to fix. That's actually quite mundane to have, but we need them to fix it. So the last one is, do you need a whole new program? And I put that last because all of that other stuff is the stuff we don't do. This we do. And that's really look at structural racism a lot of the time. Is something available? Do people have a ride? Is there food? So the kinds of things that we're trying to fix in a clinic. And then this one, I use the metaphor of the cotton gin often. A cotton gin's only purpose is to take something that's cotton right there and separate it into good and bad parts so that you can toss the bad parts out and keep the good parts. So racism does that with everything. So education, there are good parts, there's like learning and social stuff, and there are bad parts, which is crowding and, repetition and those get distributed to schools differently based on what the kids in them look like. The law, there is, even-handedness and thoughtfulness and justice. And then on the other hand, there's enforcement and thoughtlessness and, lots of other things. So healthcare has that too. So there's waiting and lack of resources and all kinds of things that are not evenly distributed that you see far more in the waiting room at Highland than you do at the waiting room at Sutter, for example. So what are the good and the bad that's available from the world that you're seeing your patient in? And so there are ways you can design programs to operate to help that. So universal interventions are things that are open to everyone. They often don't make a particular effort to advance equity, or their effort is not at least obvious. They may allow biased operations because if I haven't thought about equity, I've left all kinds of power imbalances and choice points. And they often have broad political support because it's for everybody. And my example is one that maybe had not broad political support, but the ACA for maternity care, including maternity care in there, was a really strong effort to bring a quality of care to everyone. But if it had been implemented everywhere, it would have had a really disproportionately big effect on Black women in particular, because those are people who didn't have insurance and had particularly poor maternity care. So targeted interventions are open to a limited group. All effort goes to the inequity, ensure resources are going where they're needed, and it generates political opposition. And that last one is a given. The targeted program that is the counterpart to that universal one would be Black infant health. So that's looking at Black pregnant women, looking at their infants and giving them resources just to them. The resources available, much smaller. That's one more thing I would add in there. So 2 ways to think about that kind of skirt that line are, one is the curb cut effect that we get from Angela Glover Blackwell, and there's a reference at the end. It takes a specific problem and a specific design and makes universal access. So curb cuts are an example of that. They are not invented for moms with strollers or UPS workers who've got a lot of packages. They are there for wheelchairs to equalize the world for people who travel in wheelchairs or with walkers. But they are universally available. People make whatever use of them they want. The same for OXO, handled kitchen utensils and lots of other things. They're not invented for you, but because they're universally available, people are fairly positive towards them. That was true, you could say, of our vaccine sites. We put up a tent, the tent's in the Bayview. It's meant to make it easier for people, but it's universally available. So, the people in line were a variety. They were from a variety of neighborhoods. They didn't all come from that area, but we at least increase access. So those are universal programs that might still have some equity impact. And the last is Medi-Cal doula coverage. It has really been championed by people who are interested in the maternal inequities that Black women have in our systems, but it's Medi-Cal doula coverage. So anyone who's touched by Medi-Cal and has baby would be impacted by that program. I'm going to stop really quick. So universalism, targeted universalism, John A. Powell is, and yes, it's meant to be lowercase, having lots of different ways for people. So you have a program that's got many different layered elements so that you can remove barriers and offer assistance to different people for different things. This is my great example of doing that. So the student loan program that just got released is not race-based, and yet it is targeted universalism in a lot of ways. It's a universal program, but because the average student loan debt is different for some groups, so these are the big numbers, they're Black, Native American, and Pacific Islanders are in those groups. And those are groups that have Pell Grants. So you add the Pell Grant part and you have groups that now are getting a disproportionate amount of the help, but it's not, we're gonna give it to this group or that group. There are limitations to that. It doesn't take into account differences in wealth or other things that might be missed, but at least it does give you a differential impact. So be ready, be equipped, find your problem, target policy, target choices, develop new programs, and then health equity implementation is a set of skills, not a set of beliefs. So those are all my points. Hopefully you got those. And last thing, there's a health equity fellowship that we're running. We're going to start it again in 2023. Last year, some UCSF folks did participate. It's about probably now 30 hours of in-class work over a course of 5 to 6 months and a self-study, and it covers lots of topics about implementation. This talk had maybe four different sessions crammed into it. But people did find it helpful, and it helped them use it for quality improvement and other concrete things in their work. So I will leave you very little time for questions, but the references are on the slides, which I'm hoping you get. Thank you. Hi, Margo.
Thank you. Thank you, Dr. Bennett. That is an amazing talk. And I am just sitting here trying to digest it all because there's just so much wisdom in those slides. Usually I have a question like ready immediately, but fortunately, Hakeem has given us a great question to start with. Also, I want to welcome Dr. Kevin Grumbach from Department of Family Medicine.
Ayana?
Yeah. So I'm going to just read you Hakeem's question first because it's a great one, okay? How do you navigate the health equity landscape when you've targeted interventions to benefit some historically disenfranchised populations, but seem not to have the level of engagement for other groups in need for whom the funding or grants are not available or established?
So that's where, one, we just have a disjointed system. So hopefully you are able to braid disjointed systems together. We, just like everything else in our healthcare landscape, we tend to attack a problem, and that is how we're approaching equity, or have for about 50 years. Here's a little money for Black folks, here's a little money for Native Americans, and it isn't evenly distributed or flexible enough to meet the needs of the community that the person is in. But that is the system we have. It's just like, how do we manage to give total and holistic healthcare when we've divided into different systems? We can't entirely, but we do our best. I would say that what you have control of in your scope does not need to be incremental in that way. And if you're not focusing on creating a program for something, but instead looking at the ways in which you are currently in your policies and practices generating equity, and we are, then that is not differentially funded, right? You have the scope to change that for everyone, to focus where you want to focus. So that is why I really would push people to that point.
That's a great answer. Actually, there's a request for your slides, actually,
Sure.
from Joe, which thank you for being willing to share, because I'd like to look at them too. I have another great question here that I would like to ask, which is what should people do if they feel ready and motivated to do this work, but but they're just not sure where to start. And I'd love to hear you just reflect a little on that.
So I'd like people to try to do a crosswalk between the problems that they see, and you actually have to disaggregate and look for them and tried to see those problems, and then your scope of influence. So what is it that you can actually change in your area, and how do those two things overlap? So what do you participate in? Is it regular care? Is it administration of education? What is it that you have actual control over? And then look at where that is generating inequity or failing to respond to the inequity that's delivered, because people arrive in unequal condition all the time. So that's where I would say start, disaggregate, get some data points, figure out what you're trying to change, and then what you have a lever for. And if you feel like you do have a lever or you have influence over somebody who does, then you start with that. And you may not do as well in the first couple problems. So just start somewhere where you've got some low-hanging fruit. I think we all have to be working on our own mechanics and building movement for these larger problems. But people who are effective and making change in their own daily work are going to be much more effective advocates for those larger problems than people who have just have a strong belief in it. I'm actually going to answer that question about Latinos being included in the health disparities. They absolutely are. That was actually my first example, was the COVID. It was Black and Latino groups. There are differences, though, in how groups fare on different issues. So lack of insurance is heavily, especially in California, a problem for various Latino groups and immigrants. Heart health is heavily a problem for Pacific Islanders and for Black people, and less so, but still there for Latinos. It matters what your problem is to say who you need to be thinking about. It is different for different problems, and it is different for different areas of the country. It is different for your area of influence. Maybe you have a heavily LGBTQ crowd, and it's really about that distinction. So you need to be, that's why I say be specific, because these global distinctions of include my group or don't include this group are really not relevant to your own personal work. There should be a problem you can establish and who it's impacting specifically, then we're playing a little less the politics of acknowledgement and looking at more, did it get better for that group or not?
Thank you. That's a really helpful answer. I want to ask the question from Andres. This is actually great. We get to see all the grads of our program on this list. I'm really excited to see this. From Andres, who asked, how do you recommend trying to break down the political opposition or institutional resistance? So that's part of what the normalization is for, so that people don't have what is, for many Americans, an acculturated allergy to this topic. So it just feels like it's something bad's about to happen, and people's heart rate goes up, and it just feels like it's the wrong thing to be talking about. So that opposition is really emotional and just cultural, and just getting the topic and the conversation helps with that. Hopefully you're past that point. And then you're talking about how to change things that you can demonstrate are wrong. So we benefit from being surrounded by nerds and people who care about outcomes and return on investment insurance stuff. There are actual problems that have economic cost, that have concrete data attached to them that you can correct. So we can't have quality and average. We care about things, we have quality and specific. So lots of our underlying principles and ongoing programs could include equity as one of their goals. So you're not necessarily trying to start something out of nothing. What you're trying to do is shape what is the ongoing pathway to be more specific and more efficient and more useful to you. So I would say institutions are rarely resistant to their own ongoing activities. So you're changing it rather than trying to start something new. And most of what we're trying to start that's new is specific programs or awareness, trying to get people to say things. Neither of those things are where I would say you should focus, but focus on getting some actual outcome. And most of the time it's easier to get people behind that. Thank you for that incredibly thoughtful answer. While the questions are coming in, just as this is, wow, okay. This is awesome. We really are seeing our grads on here. What are the effective ways to co-create and implement strategic initiatives with community as a way of creating more effective and equitable solutions?
Yeah, so that's one of the principles that because I could only get so many in here, didn't talk a lot about, but it's absolutely there. And the way I would describe it is that because of our really longstanding historic segregation socially from one another, the chances that you, wherever you come from, are going to be an accurate predictor of the priorities, needs, or responses of a group that you do not have a lot of social connection to, and working, and I see lots of them with patients, does not count. Sorry. I'm sure it's very rewarding, but it doesn't count. So you can't tell what's going to work or what would be most effective just by your guess or what your priorities are. So we do this a lot. We go, we just put a thing down there and they didn't use it. We spent so much money on that group and they didn't do it. It's because we didn't ask them. We set up something that nobody said they particularly wanted. We set it up in a place that nobody could reach. We set it up in a way that made it seem like we didn't do their other priority instead of this. So having those people involved is entirely required for you to be effective. So if you're looking at patients, and you're not always, then that is when you need them to be part of the conversation. Those are not skills that are usually equally distributed. So having the people who have that skill set, and it is a skill set, on board is one of the deficiencies I think that makes this hard for people. So hiring a diverse group that can actually do that for you is one of the more important deficiencies that make all of this work harder.
Thank you. We keep
that question's too long for me to get in 30 seconds.
Well, we'll give you a little longer. I do realize some people might have to go to clinic, but this is such an important last question. I'm going to go ahead and ask from Lee, which is, can you comment more on how we could better synergize between clinical medicine / population health, particularly thinking about how, due to systemic racism, what we observe downstream in the medical system, and how far more upstream solutions like UBI that would address multiple health inequities at once? That is a long question.
No, but I like the way you put this, Lee, because usually I get asked this question in a way that says we shouldn't do those other things. Isn't the real problem that we should fix racism? Absolutely, but you're not going to fix it. You're not going to fix it anytime soon. So can you just have the cops not get people in the meantime? So I think it's both. You have to have movement, which is lots of people organized around a problem. You have to have multiple institutions. You have to make partnerships. So those things all have to happen. And I do think partnership is our best way to do that. We've got lots of levers in terms of value-based care and other things that have helped motivate medicine to care about these things, but we should not be reinventing the wheel of, transportation and income and all the things that we actually have other partners in society who do. So there are institutions who do those things. Not being quite so ignorant about their existence and what they do would be a first step. And then being willing to partner outside of our own industry. So we have a partner with a transportation provider. We have partnerships with the food programs that already exist. So there are ways to do it. I would suggest partnership is our best bet, but those people need our moral authority and data to tell them where to go and to make it reasonable that this is the way you're going to fix inequity. Medical inequities are a very powerful one, and I think they don't get talked about enough. And then the last is getting those two things together. We have population health. So one of the things I'm trying to do is get our public health programs to actually be responsive to the folks in the clinics, because we can't do prevention as the only way to do public health, right? Because the communities we're talking about are already sick. So if we constantly are only talking about ways to stay well, and they're not, we are neglecting the needs of large amounts of people, and we're most neglecting the needs of the communities who are the most ill. So being able to look at things like parks and availability of food, but look at them in ways that say, what do you need people who are congregating around the clinic because you already have these health problems? what do different layers of that community need? And that's about having interactions with the community to tell you where you need to go and where their priorities are and all of those things. So needing community input. So your biggest partnership is with the community. That can be your patient community. It can be your staff community, but your biggest partnership is with community. And then you have to get past that to other institutions who actually have the power to do the things that you are wanting to be done for your patients.
Thank you. We are so close to time limits here, but I want to give you, this has been a really inspirational session with so much to think about and hopefully really opening a dialogue and a lot of thought within our department, as well as in the DPH and elsewhere. I really appreciate all that you've said, Des, and I want to just give you the opportunity to leave us with one closing thought before everyone heads off to their afternoon.
My closing thought is there is no one answer. So this was not it. There's no magic in the formula. It is the one approach that I think is being neglected that has the most leverage for the people I'm talking to right now. So it's what you can do right now, but there are other things to do. There's community engagement, there's accountability systems, there's the behavior of our payment systems. There are all kinds of things that need to get worked on, and they all need a constituency. So you have to find which things are yours. I want everybody to do what's in their scope, but you also have to figure out how are you part of the larger movement to make systemic change. So this was not everything. So if there's another question that you feel is unanswered or approach, there probably is valid and great reason to use that approach. Go for it. Just don't neglect your own scope. Clean your kitchen first.
Thank you. Clean your kitchen first. I think those are good words to end on, particularly for me. Thank you so much for being here today, Dr. Bennett, and to everyone for joining us. And again, if anyone missed any of this session or wants to see other sessions, please take a look at them on the website for Family Medicine Grand Rounds. I'm going to actually, I'll just read Kevin's words last. Because we're running out of time, but Kevin just said, thanks very much for such a compelling and lucid presentation that points to actionable steps that people can take. I would really agree with Kevin's wise thoughts. So thank you so much, Dr. Bennett. Thanks to everyone. Have a great afternoon. Bye-bye.